Hi viewers, welcome back. In today's video we are going to discuss about the management and the prognosis of multiple pregnancy. In the previous video we have already discussed about multiple pregnancy, the prevalence, the incidence, the causes and the types. All these things we have discussed in detail. So now we are going to discuss the management part and the prognosis part. So management, so I have already said you, whenever you have your management part, you have your three areas of management. First is the antenatal management, then the intranatal and the postnatal management. Okay, so antenatal management, see, now the mother is having multiple pregnancy, so this pregnancy is definitely different from the normal singleton pregnancy. So here the demand is going to be very high. She has to meet the demand of both the fetus in case if it is a twin pregnancy. In case if it is a quadruple or a triplet, like again it is going to vary. So the demand is going to be high in case of multiple pregnancy, and it is the responsibility of the mother to meet the demand of the fetus. Okay, so we have to concentrate in the antenatal period. So in the antenatal period, first area is your dietary management. So when we come to the dietary management part, so the mother has to get an adequate amount of nutritional supply. So the calorie requirement for the mother is going to increase more than the 300 kilocalories more than the normal singleton pregnancy. Okay, so again your calcium you have to increase, your iron you have to increase, so everything you have to increase in your diet. Okay, then comes the rest. So there is an increased demand for rest for the mother during pregnancy, but now during multiple pregnancy definitely there must be an increased need for rest, because what happens when the mother is taking rest, the mother is going to help the baby to increase the weight, the mother is going to improve the uteroplacental perfusion, and the blood pressure is going to get moderated. So when she is having an adequate rest, so you have to promote rest for the mother even during the daytime. So not only in the night, she has to take rest during the daytime also. So see to that she finishes her work is like early and she goes in for bed little more early than the normal period. And then comes the supplemental therapy. So you know the mother is supposed to take iron and calcium supplements throughout the pregnancy. Now the demand is going to double, so when she is having a multiple pregnancy. So all these things have to be additionally added in the supplemental therapy. And then antenatal visits. When we come to the antenatal visits of the mother, there must be a frequent antenatal visit. So like in case for the singleton pregnancy, if you have said the mother to go in for a consultation for like a weekly once or like 2 weeks once, if she is going for a consultation, then this has to be like little more early. Okay, so if for a singleton pregnancy, if it is 2 weeks once she is going, now she has to go weekly once. Then only the physician will be able to identify that the baby is growing adequately, like whether the baby is going for any complication, whether the mother is having preeclampsia, all these things she will be able to identify clearly. So frequent antenatal visits are needed. And then coming to the fetal growth assessment. So we are going to assess whether the baby is growing according to the age, that is like according to the gestational age of the mother. So you know singleton pregnancy is always different from a multiple pregnancy. You may not expect that there is adequate up-to-date growth development in singleton pregnancy, but here again it will come down, but not too much down. Okay, so there must be a continuous monitoring of the fetal growth inside the uterus. And then hospitalization. So you can always say the mother to go in for a rest, and like in some areas where you need hospitalization where the mother will be under complete bed rest, so which will promote uteroplacental perfusion and the baby will put on weight. So because like after 32 weeks you need the baby to put on weight, so when the baby is having adequate weight only, like the baby will be qualified to have an extra uterine life. So you have to help the baby to put on weight in the later weeks. So usually after 32 weeks either you can go in for a hospital admission or otherwise you can promote even bed rest at home. Okay, so it is always good for the growth of the fetus as well as to prevent maternal complications. And then when we come to the intranatal area, so management of the intranatal period. So intranatal period is from the time like you are expecting for the labor. So what all you have to do? Hospitalization, already we have discussed that you have to go in for early hospitalization. See, in case if you are planning for a cesarean session, again it has to be like little more early, you have to go in for hospital admission. And then coming to analgesics, so usually you don't recommend analgesics because like the babies, the fetus are going to be very small and like the effects on the fetus are going to be little more strong. So what happens is like there may be side effects on the fetus. So many obstetricians, they don't encourage for analgesics, but they can even prefer epidural analgesics. So if the obstetrician and the mother is willing, okay, so better to avoid analgesics. So next comes to the fetal monitoring. So you have to assess the fetal well-being throughout the labor process. Okay, as the fetus are going to be very small, so you are to be very careful during the conduction of labor. So continuous fetal monitoring is required. And then we have the internal examination. So you have to do a per-vaginal examination to rule out whether the presentation is a cephalic presentation or a breech presentation. In case if it is a cephalic presentation, you can very well go in for a normal labor. And like in case if it is a breech presentation, there are obstetricians who try for normal labor, but there are obstetricians who prefer cesarean session. Okay, so according to the preference of the mother and the obstetricians, you have to decide the labor. Okay, and then coming to IV fluids and blood transfusion. See, you have to always keep an extra line. Okay, so you must have two big bore lines, like where you need continuous IV fluids on flow. Okay, so you have your RL, that is your ringer lactate, kept ready, and your blood transfusion. So you have to assess for the blood grouping and typing of the mother, and you will have a compatible blood that is kept ready when there is an emergency. And then you have to have a neonatologist nearby your side when there is an induction going on. When there is a labor proceeding, there must be a neonatologist like to assess whether the baby which is going to be born is in a good condition, whether you need a CPR. For all those things you need a neonatologist presenting at the site during the labor process. So now exactly coming to the delivery of the baby. So you have two areas of delivery of the first baby and delivery of the second baby. So when you deliver the first baby, what all you have to remember? So first point is the episiotomy. When you give an episiotomy, what is an episiotomy? It is an incision that is made in the perineal area to help in the delivery of the baby. So it is like you are giving a pathway, you are paving a way so that the baby is getting delivered easily. Okay, so now here you are going to give a liberal episiotomy because like you need both two babies to come out, and sometimes it is like once the first baby is delivered, the second baby will take time to come. So to improve that, you are going to give a liberal episiotomy for the mother, and then you are going to have a forceps delivery. In case if the head of the baby is going to be high, you can go in for a forceps delivery. For the second fetus also, sometimes like first fetus will be delivered easily, then sometimes the second fetal head with the inadequate uterine contraction, it may be held up. So at that time also you can have a forceps delivery. And then there is no IV ergometrin after the delivery of the anterior shoulder, because what happens, like now when you give IV ergometrin, the uterine contractions will stop and the second baby delivery will be under trouble. So now always remember, when there is a twin pregnancy, after the delivery of the anterior shoulder, you are not supposed to give IV ergometrin or methogen. Then comes the clamping of the cord. So as soon as this first baby is born, you have to clamp the cord, because what happens? So as in, like, you can't wait for the stopping of the pulsation and all those procedures, because what happens? There is one more baby surviving inside the uterus. So what happens? You need adequate perfusion for that baby also. So clamp the cord and cut the baby. So when you clamp the cord, you see to that you are having 8 to 10 inches of placenta, you leave and then you cut, because like these babies are under risk. So sometimes you need a blood transfusion. In case if there is a hyperbilirubinemia, you need a blood transfusion, or IV fluids, or like for giving some injections or something like that, you may need an emergency line. So at that time your umbilical line will be the best line. So always you leave the cord little longer and then you have to cut the cord. And then labeling, so immediately label the baby as baby 1. So you assess the time when the baby is getting delivered and immediately label the baby as baby 1. Then coming to delivery of the second baby. So when we come to the delivery of second baby, so now what we have to do is, like, you have to fasten up the labor process, because like once the first baby is delivered, your uterus gets a stimulus that there must be an adequate contraction and the labor has to stop. So before that you have to fasten up the labor process and the second baby has to be delivered. Now after the delivery of the anterior shoulder of the second baby, you will give IV ergometrin, that is 0.2 mg you have to give after the delivery of the anterior shoulder of the second baby, and then you have to label the baby as baby 2. Okay, so this is the exact labor or the delivery of first and the second baby. Then when we come to the management of third stage, where we have to be very careful, because you will be facing lot of complication when you are delivering a multiple pregnancy. So what happens is, like, most of the time the mother will have bleeding. Okay, first is like IV methogen. Okay, you have to administer as soon as the anterior shoulders are coming out, you will be giving IV ergometrin you have to give. So that is to aid in the uterine contraction and to control the bleeding process. Okay, then comes the oxytocin drip. So usually you encourage 1 hour of oxytocin drip, like even after the delivery of the baby. Now again you have to continue at least for 2 hours. The oxytocin must be under maintenance, it has to flow for at least 2 hours. And then we have fluid management. So definitely there is lot of blood loss, fluid loss, so you have to give IV fluids to manage the loss. So you can go in for ringer lactate, which is very suitable at this time, or otherwise in case if the mother is having lot of blood loss, you can go in for blood transfusion, which already you have kept ready when there is to meet the emergencies. Okay, so that is with the management of third part. And then coming to LSCS, there are areas where you advise the mother to go in for a cesarean session. Okay, so where, in which conditions you tell them. So one is obstetrical indications and when there is a fetal indication. Okay, so when there is an obstetrical indication, that is from the maternal side, when the mother is having a preeclampsia, when she is unable to deliver, okay, and there is inadequate uterine contractions, or otherwise mother is anemic, all these areas, like at that time you can go in for LSCS session. And then when there is a fetal indication in the sense like both the babies are having a breech presentation, transverse presentation, and the babies are very small, okay, you suspect there may be a congenital anomaly for the fetus. In all these areas they are under risk. Okay, so at that time you can go in for a cesarean or LSCS section. Okay, so then comes the prognosis. So when we come to the prognosis of the multiple pregnancies, you have the two areas of maternal mortality and perinatal mortality. What is maternal mortality? So maternal mortality, the cases, the conditions of maternal mortality rate is increased when there is an inadequate nutrition to the mother, when there is pregnancy complications like your pre-eclampsia and typically eclampsia, when the mother is having PPH in all these regions. Okay, and then perinatal mortality when there is inadequate uterine contractions and PPH. So at that time where there is severe bleeding at the mother may go in for a complication and arrest. During perinatal mortality, you have to remember the conditions which will increase the rate of perinatal mortality. So when there is lot of operative interference, that is like in case if you suspect the mother will go in with the normal delivery, you proceed, and sometimes it goes in for an obstructed labor, or there is an atonicity of the uterus, you have to go in for an LSCS. So from the labor room you will be taking them to the theatre. So in that areas where the theatre availability, where the obstetricians or the surgeons availability, all those things takes task, and there are more chances for perinatal mortality. And sometimes when there is like atonicity of the uterus, so retraction of the uterus takes place, at that time the labor process stops. So at that time also there is lot of complications. So in these areas also the perinatal mortality improves. So there are more risk in the perinatal mortality area. So that is the perinatal mortality rate is more than the maternal mortality rate. Okay, so I think you have understood the management of multiple pregnancy, where we have discussed the areas of antenatal, intranatal and the labor area with the management of second, third stage of labor. Okay, hope there is no doubt. In case if you have any doubt, you can send me or you can ask me in the comment box. I will reply you. Okay, so take care. Bye.